One of the first questions we ask ourselves when patients diagnosed with cancer is, what's our goal? And sometimes the goal is to cure, but many times is to control the cancer. Another way of putting it is, we can't cure the cancer. And when we can't cure the cancer, we try to alleviate or minimize the effect of the cancer so that the patient can live as long as possible and also as well as possible. And that's always a balance that's difficult for us to strike. And as an oncologist, my job really becomes, how do I make it best decision? How to make the best decision for the patient in front of me? And for that, I need to understand what their goals are. What are their wishes? And we start discussing their goals, their wishes, almost from the beginning of our discussion, once we know the cancer cure is not an option. And the decision becomes, how do you balance the cancer chemotherapy or cancer radiation therapy's benefit versus the risk of the treatments? So for example, when someone comes to my office and the cancer is already spread to a different organ, so it's not curable, but they are asymptomatic, and they start chemotherapy with the hopes of living longer and living better, but the chemotherapy itself can cause them fatigue, cause them nausea, and they're actually feeling worse than the cancer itself. Does it make sense to continue? And this requires a discussion with the patients from the beginning about what makes sense for them. This is an open and honest discussion, an ongoing discussion with them. This is sometimes referred to as goals of care. Also can be part of their advanced directive or living will. And in New Jersey, for example, there is a new process in place called Practitioner Order for Life-Sustaining Therapies, where one of the first questions we ask is, what's the goal of treatment? And what does patients desire for how they want to live? Sometimes it's really hard to acknowledge that when cancer is not curable, that also means that cancer is going to cause the death. And death is something that I can't change. What I can control as the doctor is how someone lives their life. And this is where having the advanced directive, living will, or goals for care conversation are really important. Because that really helps identify the paths we will take and the decisions we'll make along the way. Having open and honest discussion with the patients is so important in this manner, so that patients are being part of the decision making about what treatments we start and when we stop. The treatments include chemotherapy, and there are sometimes different types of chemotherapy, different choices of chemotherapy. They can also include radiation therapy and at times surgery. But it can also include hospice. Now, many people may think hospice as a death sentence. I look at it slightly differently. It's one of the options I have available to take care of my patients. Sometimes chemotherapy makes sense, sometimes radiation makes sense, and sometimes hospice makes sense. It all depends on what the patient is, what their goals are. And the discussion, an honest discussion from the beginning of the cancer diagnosis, is so important in making those decisions that make sense for the patient. And each patient will have a different discussion. I don't necessarily look at hospice as end-of-life care. I look at it as part of maximizing patients' living, patients' quality of life.